Hi, everyone. Good afternoon. As people are joining us, thank you for coming. We're super excited for this webinar today. We'll give everyone just a couple seconds to join us here. Hopefully, everyone's like staying cool. I hear it's like super hot everywhere in the world, so make sure you're hydrating, staying cool. My name is Jonathan Ayala, and I am the program coordinator for the treatment division here at NMAC. We're super excited to be joined today by Amy Gottwals. I will read her bio in just a second, but this is one of our 50+ webinars. So we run the 50+ Strong and Healthy program, and that's all about really focusing on older adults living with HIV and their needs and quality of life, and really kind of letting them be the activists and advocates that they are to really push that agenda forward. So without taking up more time, I will go ahead and introduce our guest speaker today, and then she will take it over and tell us a little bit more about area agencies on aging and her work at US Aging. So Amy Gottwals joined US Aging in September 2005 and currently serves as Chief Public Policy and External Affairs, a position created in 2014. She previously served as the Director of Public Policy and Legislative Affairs. In her role, Amy leads US Aging's public policy, advocacy, communications, external relations, and membership relations activities. Representing local aging agencies, Amy serves as a lead in outreach to Congress and the administration to ensure that needed resources and support services are available to older Americans and their caregivers. She has 28 years of public policy, lobbying, and grassroots organizing experience. She has represented diverse groups, including the Older Women's League, the Center for Science in the Public Interest, the Alliance of Nonprofit Mailers, and the National Network for Youth. Okay, so I'm going to go ahead and turn it over to Amy.
Great. Thank you so much, Jonathan, for that introduction. And thank you for having me here and allowing me to come on, spend a little time with you all together, talking about what I think is the best kept secret in aging that I do not want to be a secret anymore. And that is, what the heck is an area agency on aging and what could it do for me, or what is it doing in my community that I need to know about? So I will start by making sure I can advance my slides. We'll start at that point. So the US Aging is not a governmental entity. The US is a little confusing. It's our new name of the year, but we are a national membership association that represents these entities we're going to talk about today, called area agencies on aging. We're also an advocacy voice in the nation's capital for what you'll learn more about, the Title VI Native American aging programs. So we are strictly nonprofit. We do work often with government though, and so I'm showing you this slide of logos because it's the quickest way for me to just show you sort of the range of aging issues that we engage on nationally, because our members are involved in these issues at the local level. So a lot of the logos you're seeing on the slide are projects we have with the federal government. Our primary federal partner is the Administration for Community Living. That's a relatively small agency within the US Department of Health and Human Services, dwarfed by the big agency like Centers for Medicare and Medicaid Services. It's a small agency, and it is dedicated to both aging and disability issues. And the name of the agency says it all. This is the supports people need to be able to age well and live. Well, we're all aging at all periods of our life, but for aging and disability services fall under the Administration for Community Living. So not only is that traditional elder care, but also engagement with the housing community. One of the latest resource centers is that Housing and Services Resource Center you see listed here. That's an ACL resource center. And we'll talk some more about some of the national hotlines that may be of interest to you all as you're trying to find aging resources in your state, community, or a relative's state or community, which may be across the country or a friend. So I'm very excited that we are now having so many frequent conversations between the HIV and AIDS advocacy community and aging. This is exciting. It means we are at this point where people are able to live well with this disease and now are considered aging. And that's exciting to us because we're very pro-aging and most importantly, pro-healthy aging. and giving people the choices and options they need to be able to age where they want to be. And this is never more critically important. If you're coming in new to aging, both either personally or professionally, or really just getting turned on to it, know that it's a very timely time to have you expand your knowledge of this arena, because the entire country is aging. We are going to hit demographic points in time that have never been seen before in this country. We are growing older, like some countries in Europe and Japan. This is a long-term demographic trend. You can, yes, point fingers at the baby boomers. It's not their fault. They're going through yet another life stage. And that, combined with the fact that people are living longer, then that means we have this real surge in the population. And so in just 7-8 more years, we will have 20% of Americans will be age 65 or older. And we certainly know, and probably the reason you invited me here, is that people living with HIV and AIDS are living longer themselves. And so this is now this pressing issue, which again is still a victory. We want to do what we can to support everyone being able to stay in their homes and age healthfully for as long as possible, because that's where they want to be. This stat kind of varies year to year. It's credited to AARP. They have the bandwidth and the number of members to do the survey and get good data. But suffice to say that anywhere between 85 to 90% of people, when you ask them where they would like, how they would see the remaining years, where they want to live, usually it's in their home, or if not there, in their community, maybe in a different type of home or housing situation. This is what people want. Nobody plans for when they're going to live in a nursing home. People might think they might want assisted living or independent living until they see the price tag. So this is by far and away what people actually want. And the great news is actually providing these services at home and in the community usually saves both government dollars and personal dollars from the individuals who are doing that aging in place or their families. So I'm going to go back in time a little bit here to a really pivotal summer in policymaking that has really changed the course of what aging policy is today and what the experience of older adults is as far as interaction with federal government programs. So I'm going to talk about a lesser known federal program called the Older Americans Act. Here's a picture of Lyndon Johnson obviously signing this into law in the summer of '65. And this came just a few weeks before two other massive federal programs that you do know, Medicare and Medicaid, were also passed that same summer. Just think of how productive Congress was, that was, it all happened within the same summer. It's just mind-boggling now. They usually take off in summer. But it was part of course, the war on poverty and high poverty rates among older adults, really terrible poverty rates. And so this was really seen as essentially a three-legged stool. You have the healthcare part with Medicare, you have the social care part with Older Americans Act, and then obviously Medicaid was broader for the war on poverty to shore up, provide all types of health insurance, and later on long-term care for people with low incomes. So the Older Americans Act is not anywhere near as well known as these programs for a couple key reasons. Most importantly, it never was funded in the same way that those other programs were. And if you know how those work, once you're eligible for those programs, whether in Medicare, you meet all the federal criteria, or for Medicaid, if you meet the state's criteria, because that's a federal and state program. So some of the eligibility requirements can vary from state to state, as many of you probably know. So once you're in, though, you're in, and the funding is spent by the federal government, or in Medicaid, the feds and the states. But for the Older Americans Act, we have to go and beg Congress every year for funding, and that'll come into play. I'm going to talk about the limitation of some of the programs our members offer, because it's not, once you're in and you qualify, then you automatically get the services. So I want to draw that distinction now, and not growing in size because we're not on automatic growth the way that Medicare and Medicaid essentially are. Congress can change those programs, but let's face it, they hardly ever do. And usually when they try to change it, sometimes it's bad, and we all as advocates fight to stop it. So just understand that this is on a really different track, which is probably why you may not have heard of it, or and it hasn't grown to the size that it really should have in order to provide these, what's now being called by the healthcare industry, social care, and what we in the community call home and community-based services. But what the Act did is it set up the infrastructure that we are still operating as a national aging network today. AAAs weren't added until 1973, and I'll talk more about that, but I'm going to stay broad for a minute beyond my AAA members and tell you just the breadth of the program, because there's multiple levels of governments and players involved in how the aging network works. But philosophically, what you need to know is these are the folks who were at the state and local level and the feds tasked with creating a range of options and services in community to help people be able to meet that goal of aging well in place. I mean, the terms change all the time, what we're calling it. There's always somebody finds a limitation in what we're calling it, but really giving people the options they want so they can both stay safe, but also stay as independent as possible with a little support. Given the limitations in funding, that, as I said, there's not that, oh, you meet all these requirements, you're in. But Congress has recognized the fact that we cannot serve everyone under this act, given the money that they give us. And so they have, over many decades, created what's called targeting language. And so it directs the players in the National Aging Network, that I'll talk about who those are soon, it directs them to prioritize certain populations, and some of those are listed here. So we are focused on those who are most in need of these services, some through some demographic information you can see here, people of color, low income, limited English proficiency, but also those who are most at risk of nursing home placement, and so who desperately need these services or they won't be able to remain in their home. Like any piece of federal legislation, it gets updated over time. And this is not where the funding comes. This is where a different set of committees in Congress come in and look at the act that they've authorized and say, what else do we want to change? What else is coming up? What innovations are happening in the field? So this is pretty wonky slide, and I'll move on, but I did want you to know that it wasn't like it was all created in the 60s and 70s and hasn't changed since. I will say that there have been less bold reauthorizations of the act in the 17 years I've been doing this, because that's what it takes to get bipartisan support these days. But know that over time, the range of services offered has expanded. And the most recent example of a bold change was that 22 years ago in the 2000 reauthorization, there's a whole new subtitle created to focus on family and friend caregivers of older adults or older adults who are caregivers. So before I move on to the realities of what this act actually funds and its relation perhaps to you and your families and friends and communities, I did want to just tell you, because it's such a beautifully written act. In Title I is the declaration, and you can see that the drafters of this legislation had very high goals on what they wanted to focus on for this piece of legislation, and to really carve out a vision for what people need to be able to age well. And so this really runs the gamut. I mean, there's everything in here, from employment, from income security, housing, all of that. But that, unfortunately, is not backed up by funding. There are several other parts of the act that aren't just the declarative statements and the visioning, that actually is where the rubber meets the road, and they did provide funding over time, and we've been able to make local options flourish thanks to this federal funding, which becomes the bedrock. So part of the act establishes who the federal agency is, and it's the U.S. Administration on Aging, and for a long time it was just a standalone Administration on Aging. The federal agency I described at the top of my remarks is an umbrella agency that was later brought in to kind of unify aging and disability under that community living umbrella. So there's still an Administration on Aging, it's just within Administration for Community Living. But the bulk of the Act's funding and also service delivery is what's under Title III. And these are where grants go out to states from the feds. And then we'll talk about my members' role, because that's the next layer down in that process. And there are several key subtitles that we'll talk a little bit more about. The other thing I want you to know broadly about the Older Americans Act, because I'm going to show you ways you can get involved in the administration of these programs locally if you're so interested. Know that there's also an advocacy charge specifically to my members, that they are an advocate for older individuals across a range of issues, and that they should get involved at every opportunity to do that advocacy. And you don't usually see that on the service delivery side. This is tends to be unique. I've worked in youth work and done some other areas, and you don't usually see Congress telling you, now go ahead and do all this advocacy. But that is a part of their role that I want you to know, because it's a good stick too, to remind aging network entities that they need to do some advocacy as well as deliver the services. So I'm going to drill down a little bit into what these services are, because I think that is usually the most important thing that people care about, is what is it you're actually offering. Under Title 3B of the Act is what we call supportive services, or sometimes we call it here home and community-based services. This is actual in-home help supporting you with your activities of daily living. You know, there are meals programs in the Older Americans Act, and that's what everybody tends to know. But once my hunger need is handled and my nutrition is handled, if I need help showering and getting dressed or leaving my home to be able to go to doctor's appointments, I'm going to care a lot about these services as well. This is the most flexible pool of money that area agencies on aging have, which is tremendously important to them, because what it allows them to do is offer the services that are listed on this slide, but also have enough flexibility that they can customize what they're offering to who they're offering it to, what people actually need. And in our field, we call this, I don't know if this is universal across other population groups, but we call this person-centered care. And so know that the Aging Network is very focused on person-centered care, as much as their siloed funding streams will allow them to be. What is it you actually need to thrive and stay at home? So here are some of the services, but there are about 20 more other services that AAAs can use this funding to create these options in community. A subpart of that is also the very front-facing kind of first layer of how we're helping people. So it's not just the meal, the ride, someone coming in to help with chore services in your home, or basic housekeeping, or that aforementioned shower that you want to have. There is also a lot of information and referral and assistance that goes on. So all AAAs and all states have some sort of hotline, call center set up to help get information out to anyone interested in these aging services. Then, of course, there's layers of other folks who have similar outreach jobs, like case managers, benefits, and other eligibility for programs, counselors. In our field, this is outside of Older Americans Act, but we also have some health insurance counselors. So state, we'll talk more about that later. And then other types of folks too, focusing whether on elder abuse, or increasingly we've been working with hospitals and health plans to help people transition back to the home from hospital stays. We know that often does not go as intended by the acute care side, especially when you're dealing with older adults. And so we've been working to provide the transitional care going forward. And then other key titles of the Act, the aforementioned nutrition programs, those are really two major areas: home delivered meals, but there's also what we call congregate meals, and that is what you think of. People mostly think of lunch served in a senior center. It's in all types of community centers, sometimes intergenerational. Increasingly, the network's looking to find to push the envelope even further and look at having these programs in restaurants, giving people more choice, having that also often allows them to be more culturally sensitive and have a wider range of menu items if you're partnering with restaurants. But the idea of the congregate meal program is that you are doing that in groups. Obviously, things have looked a little different with COVID. Those were the first types of programs, along with Adult Day, to shut down at the start of the pandemic. But know that we are planning on, over time, more and more bringing those back, because the reason that those programs have been so successful is it provides that connection and community for the people. It's not just the nutrition, it's also the connection. Home delivered meals obviously make some are effective in helping with social isolation, because volunteers, or the pandemic, it was more often staff delivering those meals. Sometimes that's the only other person the home delivered meals recipients will see in that day or that week. And so that's a really important connection, but we want to also keep up that gathering in community. I mentioned before the Family Caregiver Support Program. So I want to just detail a little bit what that looks like. This is respite care which is taking care of your care recipient so that you can go do something else, go to a family reunion, take a few hours off to go to a caregiver support program or go do something fun. This is the most in-demand service, and so it can be limited on how many hours are available, but it's a really important service that we offer to family caregivers. There's also other forms of support that can be offered to caregivers, as well as education, training, support groups, etc. All these ways to shore up these essential caregivers. Now, I'm using the term family caregiver, but it's a pretty broad definition in the Older Americans Act. So it's not all just biologically related family. It's the broadest definition of family, which is great. So I will note, though, that this program applies, I haven't brushed up on the law lately, but I think I know this. But this is for any older adults. And the Older Americans Act, I skipped over this, but the Older Americans Act applies to people who are age 60 and older. It's not the 65 of Medicare, and people think of older, often draw the 65 line. Older Americans Act is actually 5 years younger, age 60. So it's older adults who are caregivers, and it's also younger people who are caregivers of older adults. There is a, unfortunately, way too small, only like $25 million program that is focused on offering evidence-based health and wellness programs. And I want to flag that one of the most commonly offered programs are chronic disease self-management classes. Sometimes those are on specific diseases like arthritis or diabetes, but a lot of this can be sometimes applied to other chronic conditions people are managing. So I wanted to flag that. I don't know off the top of my head if there are any examples of this focusing on HIV. Be a thing to look up, and I can circle back with the federal government who may know exactly if any of these are authorized, but I wanted you to know those exist too. And then just briefly, there are some other titles of the Older Americans Act, a labor program that is at the Department of Labor. Older adults job retraining and getting them employment. This is for older adults who absolutely have to work to be able to remain independent for their own income security. And I mentioned, and I want to mention again, Title VI, Native American Aging Programs. This is the other type of membership that US Aging has that I want to flag. They largely operate in Indian country, but they can serve elders wherever they live. And they often partner with local AAAs to strengthen those services. That doesn't mean this is the only set of options for Native American or Native Hawaiians, of course not. They can get services through the AAA network in the States, but this is an added, very specific program which gets very little funding, but is obviously critically important. And there's also an elder rights title of the Older Americans Act, and one of the programs I will flag for you there is that because it's really different than what the rest of the act looks like. We're all focused on keeping people at home and in the community, but we also care a heck of a lot about the older adults and people with disabilities who are residing in institutional care, like nursing homes, and now also assisted living. And so we have what's called long-term care ombudsmen who advocate for those people for their individual needs in those institutions. That is also largely operated at the state and somewhat local level by the Aging Network. They operate these programs as well. So I just want you to be aware of that. So if you think I'm worried about what's going on in that nursing home, know that there are long-term care ombudsmen in most communities and in every state. So I've been talking about feds, states, it might be getting all blurry together. So I just want to flag, there's that Federal Administration on Aging under the umbrella of ACL. Every state office has a Department on Aging. Increasingly, they're merged with disability departments. Sort of increasingly, which I don't love, they're merged with Medicaid, but they all have authority granted under the Act. And then my slide is wrong. It is 617 area agencies on aging now around the country. That's usually a very stable number, and they have an important role we'll talk about in a second. But if I were to do this in a pyramid form, which I don't love because it's hierarchical, but at least the base of the pyramid you need to know is what's the biggest. And that is the estimated to be 20,000 local service providers. These can be an individual home delivered meals program, a transportation agency or service, just very community-based organizations who partner with states and AAAs to deliver these services. So what sets AAAs off and different from those service providers is that they have a very much across all of those programs, across all the aging issues, they have a planning, developing, coordinating, delivering role. So I say this because it's important to note that they are overseeing the rest of that aging work. So if you were coming at this from an individual perspective, then if you connect with the AAA, they know everything that's available. Lots of great aging service providers will also know what's available. They'll send you back to the AAA if you also needed transportation, but all they offer is meals. But I do want you to know that, again, that with that umbrella metaphor, the AAAs are over all of those local service providers, and they are charged with figuring out what older adults need in their particular planning and service area, and then going out and building that, working with those community partners, working with older adults. AAAs are in almost every state, but I've listed in my second bullet the exceptions. Those are either, I can't explain Nevada and New Hampshire, they should have AAAs, but the Delaware and Rhode Island are so small, it didn't seem wise to the state to subdivide it. And the Dakotas and Wyoming, it's a sparsely populated issue in which that the state didn't think that was a good system to set up. But as I said before, AAAs aren't coming and going very often. There's just been a little changes over time. So they all have that same charge, but they also look a little different based on a couple criteria, and that would be AAAs. So they're not all one type of thing. They're all designated by the act. They have this congressional mandate to go out and do this work, but because states were allowed to decide how to set up their AAA networks, kind of at the get-go, they can't come in and reinvent it all the time, but they got to say in the beginning, then that means that based on the history and the governmental structures that predominate in that state, that affected where the AAA usually sits. So you can see we've got like under a third in city or county governments. If you're in the Southwest and Southeast, the AAA may be part of the Council of Government or Regional Planning and Development District or area, because that's the structure that often takes the form of coordinated government in those areas. And then the majority of AAAs, however, are independent nonprofits who, again, they all share this role. And because it got divided up by different states, you have extremes. You have New York didn't do exclusively counties, but is almost all counties. So there's 59 AAAs, and they're everybody there would have one county. But in Wisconsin, you have a AAA with like 17 or 27 counties. I can't even remember. There's only 3 AAAs. So there's some of that variation. Again, core mission, doing the same types of things, but there is this local flexibility. And I should mention that was the intention of putting in the AAAs. It's not a bad variation. It's intended to have the local community be reflected in the programs and services that are developed, that you don't just have a state put statewide grants out. So to give you a sense of the size of these agencies, there's a huge range because of everything I just said about depends on where you sit, depends on how much of a territory you cover. But here are some averages of the number of staff and volunteers they have. You can see volunteers dwarf them. And here is average funding level. These numbers are a couple years old, so they do not reflect any of the ample COVID relief dollars that the network got, which is probably good because that skews it. But you can see in the parenthetical note under the 10 million, just how broad that range is. So you have some small AAAs and you have some that are exceedingly large, but they don't, even though I'm spending the bulk of my time talking about Older Americans Act, I do want you to note that 39% when you look across the average AAA budget. There are some that have it at 90%, but for the most part, most of them have other sources of funding. Most commonly, Medicaid home and community-based services waiver, very similar programs to the Older Americans Act, but just paid for out of that program where you have to qualify in order to receive services. They also do a lot of leveraging of other funding. But regardless of the size of their budget and their staff, they all have to deliver these set of core services under the Older Americans Act. Now, we talked a lot about these, so I don't want to spend a lot of time on here, but just know these are core services that they all have to offer. And we talked already a little bit about how they offer information referral hotlines and call centers and really are doing a lot of outreach in the community. What I want to tell you about next is if you don't know where to find your AAA, because there are challenges in the naming and in knowing what your state system is, I've got an easy fix for you. It is the Elder Care Locator. This is a national call center. My organization does operate it, but on a grant from the Administration for Community Living. So it is federally funded, federally authorized, and you can see our hours and contact information. But what you need to know is this is how you can find not only AAAs, but any other aging services. It might be a state program, and maybe it's the feds that we need to refer you to, but our call center can get folks where they need to go. And that's for professionals, actual consumers, caregivers, really anyone who wants to find out what the resources are in their community. And one shout out I'll give is that we also have a lot on the Elder Care Locator website, a lot of brochures that can be great conversation starters in your community with your friends. You might need to encourage them to give up the keys. We got a brochure for that. So lots of issues around aging. We put out very simple consumer-facing brochures that may be able to be a resource for you. The first copy is free, then there's a modest charge after that, but it's also, these are all available online and you're welcome to print them out and use them that way. And then recently, that Administration for Community Living was able to use some COVID relief dollars to stand up a disability line similar to the locator. We're focused very much on vaccines and getting people with disabilities vaccinated and boosted. That's the thrust of this work, but we're hoping this turns into an ongoing call center where we can meet their needs and get other information about disability programs going forward. We are involved in this, but we are doing this with 5 national disability groups. They're bringing all their expertise and perspective to the table, and again, funded by the federal agency. I mentioned before, it can be a little tricky sometimes to find AAAs, and so I'm going to give you this tip. The issue isn't that we don't have that wonderful call center and you can look it up by zip code. You don't have to talk to anyone if you don't want to call. You can do it by zip code on the website. But the AAAs didn't stick with that clunky moniker that was put into law in 1973, and you kind of can't blame them. Our name used to be National Association of Area Agencies on Aging, and we changed it about a year ago for all the same reasons our member changed it, wanting something that really speaks to the broad mission of what they do and is more consumer friendly. So just because they don't have area agency on their aging in their name doesn't mean they are not an area agency on aging. Although usually if you look on their website, you'll be able to see they'll talk about themselves as the congressionally designated AAA. So I wanted to give you that outreach. Don't be thrown by that. And then there's lots of other programs that AAAs operate that sometimes people think, oh, that's the SHIP or that's the ADRC, but they're still an area agency on aging. That's still their congressionally mandated role. So to speak more specifically to that, these are some of the other types of programs outside of Older Americans Act that most AAAs, and you can see the percent here, are operating. I already mentioned the one at the bottom, the Long-Term Care Ombudsman Program, but there are also a lot of work to coordinate aging and disability resources together. And so instead of building some new thing, when we had the Disability Network and we had the Aging Network, the feds have for many years now tried to invest, and states have really had to pony up most of the money to have what was probably badly named Aging and Disability Resource Centers. They're not always centers. It was really about connecting the technology so that if someone really needed an aging service, but they happen to come in through a disability organization, that's okay, because all the players in the community know where to find the other resources. We call it a no wrong door system. Wherever you knock, wherever you walk through, we will try to help you find the services you need, and they're partnerships between aging and disability. Some AAAs made it their name, to my eternal frustration, but know that that's a project, and that may be especially important if you're going to look for aging services but are under age 60. An Aging Disability Resource Center will know about other services that may be available to those younger than 60 that mirror what we do in aging but are on the disability side. And finally, importantly, we know how confusing Medicare is. Anyone who's ever supported someone on Medicare, helping them make choices and interfacing with the healthcare system, or gone through it themselves. And so please know that there is another federal program that's done in concert with states called State Health Insurance Assistance Programs. These are Medicare focused, despite the name. And so 2/3 of AAAs also provide on the ground help. These are really trained volunteers who, when it comes to pick your plan and maybe your drug list has changed and your health has changed, and every year in open enrollment, you want to figure out what should I pick if that's you have a particularly complex situation, you're not able to find the answers you need on Medicare.gov or 1-800-Medicare. Please know these programs are out there in every state, and they provide hands-on help to people They're non-biased. They're not brokers. They don't work for the plans. They're helping you figure out those programs. So I wanted to mention that. And I need to wrap up on time so we have time for questions, but I'm just going to throw at you some other examples of who else these agencies are partnering with in the community, some of the other data that we have. They're invested in Medicaid. They certainly work with adult protective services and many other entities that are out there. And I think COVID made this even more acute. Everybody had to work together to recreate the services to meet what was escalating need, increasing complexity of need of older adults, especially the longer the pandemic has gone on, and social isolation and loneliness has had some very negative effects on older adults' health, particularly those that we serve, more likely to have challenges that don't, that another layer of isolation on top of what everyone experienced in the pandemic to some degree. And these slides just reinforce what I said. I talked almost exclusively about Older Americans Act, but please know these agencies have other resources and are know about other programs. And here's just a couple examples of the other places that I'm saying getting funding, but what you need to know is they're read in on these programs and they can help consumers access these programs, whether it's home energy assistance or other programs set up at the state and local level to help people live their best lives and be healthy as they age. And lastly, other movements that you'll see AAA is involved in besides what I'd already mentioned, the evidence-based health and wellness programs, because not just about those who need acute services, but it's also about creating healthy aging in a community and opportunities to age well. We've long been involved in the livable communities movement. That's more and more being called age-friendly communities. And there's now an offshoot of that we are taking a leadership role in that's around dementia-friendly communities. So if this is of interest, and I hope it will be, this is another thing that it's easy for individuals as well as organizations to get involved in. And I clarified this, but I'll clarify it again. The core set of services we talked about, AAAs can only offer to people who are age 60 and older. But they are increasingly at least able to give some access and information and some services to people who are under age 60, given the fact this is a 50+ group, and what I've learned from Jonathan and from other experts in your field who talk about the advancing aging that can occur, people living with HIV. So these are some of the other types of folks they are able to serve, and these are the kind of services they offer them. And so again, it's not the same exact set, but they can also be a good resource to help you get eligible for any other existing long-term care programs, helping you figure out different options that may come up around aging or living with a disability. So I already said this, but here are the different ways you can find out what AAA is in your area. Again, it might not call themselves a AAA, but if they're listed as the AAA, then there should be your first starting point in your region for understanding what exists in the aging network. Not trying to turn my back on states, but let's face it, you want to be talking to folks who are in the community, not necessarily at that statewide level. They do great work, they oversee these programs, have financial responsibility, and lead some statewide efforts. But where the rubber really meets the road and the services are delivered is the AAA and their community partners. So I threw a lot at you, and it took me even longer than I thought, and I want to leave time for questions, so I will stop talking now. But I'm really interested in seeing if you have any questions. I hope that you will get to know your AAAs, refer people to them, and here's all my contact information. If you're not having a great experience, you now have this as well, because I would want to hear about that. And so with that, I'll stop. I'll turn it back over to Jonathan or whoever's taking it up from here. Maybe it was Damian.
Hello, hello everyone. I'm Damian Cabrera, Program Manager for the Treatment Division, and I wanted to thank you, Amy, for this amazing presentation. And one of the reasons why we wanted to have you as part of the HIV 50+ Strong and Healthy program is that obviously most of the I guess the most obvious way to look for services for people living with HIV is to go to Ryan White, right? But there are so many other services, as you have explained, that we wanted to kind of broaden that perspective and provide people with information of where they might might go. At the beginning of the presentation, you were talking about OAA and kind of the history behind it, and I was really interested about what you were mentioning about how current services are not only about, for example, providing meals or a ride or something like that, but I think you hinted about like structural type of barriers or situations that people might have. And one of the things that we talk about a lot in the HIV field is about how OAA might be improved. Many of the advocates are focused on that. If you can give us kind of an insider's perspective of how do you think that might look like, or give any type of hints to advocates on, what areas do you think they should focus on this, improvement of OAA?
Okay, well, that's a great question. Let me think about it two ways. I think nationally, so from a federal advocacy perspective, we'd love you all to join in with, it's not just US Aging. There's an association for all those different types of providers. There's an association for the state units on aging. And we have lots of colleagues from other aging groups that love the Older Americans Act. So we all advocate every year through a major national aging coalition for more funding for the act. It's really quite small. Just over $1 billion for those core programs for, it serves 11 million older adults, but we know so many more people need these services. So I certainly welcome anyone's advocacy in getting to know these programs so you can advocate effectively for them, of course, and help us support more funding for these as well. That's sort of a national perspective. The second national perspective, I guess I should say, is real dramatic changes to the act, like my very wonky slide at the beginning. Those only come up every couple of years when Congress isn't giving it annual money, but when they really pull it out and go, okay, what do you all want to change this time? It's very hard to get big changes, as I mentioned, but that process is all the stakeholders get involved. We get a little cutthroat, the lobbyists lobby each other, but all for the benefit, we hope, for the older adults and caregivers who are served by the act. So that's another advocacy opportunity that won't come up for a little bit longer. It's up for reauthorization in 2025. So probably groups really start talking about that in 2024. So put on your long range calendar that would be another opportunity. And I know many HIV groups have gotten involved in the last reauthorization, which happened literally before the pandemic. Previous president signed that like days into the pandemic. So we got lucky that was done, and our active advocacy really helped us get COVID relief dollars too, but that's another thing. But locally, there are ways for you to get involved in your AAA. So first you got to go find out what they have, see if it matches up to what I told you. I hope it does to some degree, to a lot of degree, actually. I'm only setting up good expectations. But then if you're something that you're not doing, but is happening in another state, we certainly, part of our association is to get all our members at their best. We just had our national conference. People were thrilled to be in person, sharing ideas, but always more can be done to be better. So bring your ideas to that AAA. A couple ways to do that. They develop area plans every 2 to 3 years. This is, again, in the law, they have to do this, and they have to get stakeholder involvement. So when you're getting to know your AAA, read their area plan, usually not that many pages, nothing too daunting, and then find out when they're next going to update it, because they have to hold listening sessions and stakeholder involvement, and that would be a great chance. You don't have to be an organization, you can be an individual, you can be a client, a potential client, someone who just wants to be an advocate for everybody, and so you can go in and get involved that way. Another more ongoing formal way is that every AAA has to have an advisory council at the local level, and those advisory council members, it's very dictated who they should be on there, and it has to reflect older adults in that community. So that's a tremendous advocacy opportunity for older people living with HIV, whether you or you're a professional in that field. That is ideally we want the actual consumers, but please ask your local AAA about that. They are often looking for people to serve on these councils. It's a volunteer gig. It's important, and it really helps inform and becomes a voice of the people we're trying to serve, making sure we're serving all of them and all populations within this big population of aging to the best of our abilities and in the best possible way. So I would say those are those two advocacy opportunities. There are also other things that happen at the community level at aging that the AAA may be involved in, but others are too, like having cities and counties become dementia friendly. And having individuals, there's a Dementia Friends movement that you can check out all from our website. That's one of the logos I threw at you guys. So there's other ways to get involved in aging advocacy work that may or may not be housed with the AAA. But I do hope you'll know what those services are, what it looks like in your state and area, because you all can be tremendous advocates for others. Because some of us are always the oldest in our friend group. And when you experience friends, neighbors, colleagues, it's great to be able to say, you know, there are some resources on this. And please know, I've gone as a middle-class person with middle-class parents who had resources. I still went to the AAA. They still knew the best durable medical equipment place. They still knew how to refer me to the best home care agencies. So these are still resources, even if you don't receive direct services from them. They are the experts in the community on aging.
Awesome, great. I think that's really helpful, and I know we have a group of advocates that I know are going to be super interested about what you said and how they can get involved. Now I'm gonna switch it over to Chip. Chip is the director of communications. He's in the in the backstage of this webinar. Chip, if there are any questions, can you read them out loud?
Oh yeah, there are questions. First question, what is U.S. Aging doing to advocate for inclusion of persons aging with HIV among those of greatest social need under the OAA, both by the federal government and by the individual states?
There is the advocacy on display. Good for you. Okay, I knew that question would be coming. Okay, I have to get wonky on you all though. So I did mention the targeting language in the act. So for those who are not sure how this fits in, I'll just give at least my understanding of the question. There are, in addition to the people I specifically called out on there, right? Low income, they use the term minority, those at risk of nursing home placement. There's sort of another bucket category called individuals at greatest, oh, of course I'm gonna flub it, but it's greatest economic and social need. Yeah, I was thinking risk of the greatest social and economic need. And it allows a lot of flexibility for that to be defined. Some states have gone in and put some parameters on that. Many don't, and it allows the AAA to kind of define what that often looks like. As certain groups have felt left out from those buckets, particularly LGBT community, some really fierce advocacy over the years from my friends at SAGE, and also the HIV community, there's been advocacy in the past couple reauthorizations to say, we want to be spelled out in there. We believe that our populations fall into greatest social and economic need, or one or both. And so here's why, here are the facts about the population. And whether it's the early aging or the income inequities and lack of familial support in LGBT population. Okay, sorry, stalled out. So that's been the advocacy ask. US Aging has for a long time not taken pro or con positions on the targeting language. And that was because we wanted to be able to it puts our members, they're already facing these local challenges of meeting the needs of everyone. They're given the targeting language by Congress. Studies that have looked at, do we target effectively? Are we serving more of the people who said to be targeted than we are the general population? And that's always come back successful. So they didn't want us as a national association to be deciding who else got added or who we were saying shouldn't be added. So we stay out of those conversations. There's just a few aging issues we stay neutral on, and it's that one, and it's and you all, as Ryan White advocates know, formula fights that I know used to break out regularly around Ryan White. We have the same issue around formula fights when reauthorization comes up, and we stay the heck out of those. So we're not going to champion that specifically. I will tell you that many of our members are championing that. And so if your local AAA isn't, you're certainly welcome to advocate that to them to say, is that something, is the state giving you guidance? Are you prioritizing this population? Here is our concerns. Can you work with us? We can bring expertise, we can bring first person advocacy, we can be on your advisory council, you know, whatever you're offering them, make that request that you would see that. There are states and AAAs where this is already a priority population, I believe, and maybe more, maybe LGBT. I'm not positive on numbers, but you're not starting from scratch, and so that's something you can absolutely do. Nationally, we don't want to pick some and not others, and so we say Congress. So that is a little bit lame, but that is where the association has been most comfortable. But I know that many of my members will be very open to getting feedback on that at the local level. And you may have to lobby states too, who often then have power over setting those rules. It may not all be at the AAA level, but that's still a great starting point. And they can tell you what other conversations have happened at the state. Another quick point, I know I'm giving really long answers. The regulations for the Older Americans Act, of which there are very few. We're not a heavy reg, we're not healthcare, we're social work. So we don't have a ton of restrictive regulations, but they hadn't been updated since 1988. And the world's a very different place. So the Administration for Community Living is in depth writing new regulations to reflect the entire act. There's parts that have no regs because they were put into the act after it. They've already first had a little request for information. I'm sure there are HIV groups, and I know there are LGBTQ communities who wrote in and wanted some more clarification in the regulations around the population issues and targeting. I think you have very friendly administration to these concerns. So it's there. I think there are some windows of advocacy opportunity there. So as far as timing on that, they're going to come out with those regs. Nobody knows. Probably early to mid 2023. So if you can stay in touch on when those regs come out, that would be another, see what they say, and then be an advocate and say, nope, you didn't go far enough, or can we do this? They have to adhere to the law, which doesn't spell out these two populations I've been referencing, who've been trying hard to get into the act as a targeted population for a while now. But that's another advocacy opportunity that'll be coming down the pike probably next year.
Okay, next question. Older persons with HIV are largely pre-frail or frail with multiple comorbidities, single and living alone without children with low income. Are any services tailored to our needs, and how would we learn of them?
You know, I was on a prep call the other day for a presentation at the Ryan White Grantees Conference that's in August, and my colleague from the Administration for Community Living had some really strong examples. One out of a AAA in Phoenix, Arizona, that has had this for decades, that saw the need and really customized some programs for people living with HIV. But it's not common that it's carved out in that way. There's not, our members have never had the resources to be, they target who's receiving the services, and we come at it from a person-centered, what is it you need? It's not you're eligible, so you get these 5 benefits. So I think we're good in that way, but they haven't really around any other diseases either carved out. Some of those evidence-based programs have focused in on particular diseases, as I mentioned, but that's because the people who demoed these and researched them, you know, were taking very common diseases. So there's not a ton that's very focused on this population, but that doesn't mean there couldn't be in the future. I think as more and more folks from your community age into our community, our collective, we're all aging community, that may be something that you can advocate for and bring your resources and knowledge and firsthand experience to help inform what the AAAs are doing. They are right now struggling with a lot of workforce challenges. The direct care workforce is a hot mess, and it's really hard to keep and retain, well, that is retain, recruit and retain the workers who do this provision of care in the home. So they're under a lot of strain. So any other partners, individuals or organizations will be welcome to them if there are some cultural competencies, some specific issues, ways you think they can do it better, so that when they are working with people living with HIV, it's person-centered support.
Okay.
Examples. I need more examples so I can have a better answer on that one.
Okay, next question. Is there any specific legislation that covers people over 55 aging with HIV, since this population can develop symptoms of aging at an earlier age than 65?
Well, That's not to my knowledge, but I also am turning back to my hosts here today to see if they know of any other legislation. I can't cover every piece of aging legislation. Like I said, there was advocacy to call out the population in the Older Americans Act, but I don't know anything targeted, like you said, particular legislation. Sorry, I can't
Okay.
answer that.
We've had a couple of requests from materials and services from you in Spanish and other languages. Are materials and call centers available in Spanish and other languages?
Any of the brochures I put on the screen are also in Spanish. We're moving to always do it in both. The call center, I don't remember how many languages, but we have tons of bilingual operator, that's not the right word, information specialists. So yes, we absolutely, you can talk to real people in Spanish for whom it's their native tongue. And then for other languages, we have, I'm fading, I'm losing my words. We have services to do translation at the now I'm speaking now the elder care locator. Our members work really hard to have offer as many information, as many languages as possible. I will say that's going to vary where they are. In San Francisco, a really well-resourced city agency with great sensitivity to meeting the needs of an incredibly diverse population, they probably have more materials and services available in multiple languages than a one county rural AAA. I mean, just to be real. But that certainly is something we can, again, are willing to accept advocacy on behalf of making sure we're meeting. It's top of mind for our members, particularly in the last few years as people who maybe weren't paying it the heed they needed to before, turn and look more closely at their own DEI and belonging efforts. There's real desire among our members to do better than they historically have in that space. And so I think they will also welcome your advocacy across the board.
Awesome. I think perhaps, Chip, if we have one short one, if there is one, we have.
I'll try to do a short answer.
Just for a lot.
Sure. The next question is HIV recognized as a disability for DIAL?
Oh, that's a great stumper, but I don't know. I need to find out. I don't know. Wow. No one's ever asked me a question about DIAL. It's so new. I will get back to Jonathan on that. I certainly think that I'll answer this way. For calling, for tapping into resources, sure. We don't turn anyone away at either call center. It's just who you're going to be connected to for local disability services, if indeed that's where the need is. That I can't control the definition for a particular program or within a particular state. But for if you're calling, everyone's welcome to call. So I'm going to correct that I'm saying I don't know. Everyone would be welcome to call. Some older adults call DIAL because that's what they saw out there. We certainly have younger people with disabilities who call the elder care locator. It's the same. It's two teams next to each other in a call center and in their homes, remote. So we'll do whatever we can to help people find resources that apply to them. I just can't speak to the universality of disability programs in HIV because I'm not the expert. My hosts are.
And we're all learning, and I think that's what we'll end here with is this is so amazing because I feel like I learned so much, and I hope that everybody else learned so much as well, because this is a huge kind of behemoth of an issue, right? All these agencies and acronyms and kind of all of that. So you've really kind of broken that down for us. So thank you so much for your time and expertise, Amy. We really do appreciate it. And just to everybody who's watching, this is being recorded, so this will be on our NMAC website. We'll post this on a 50+ Strong and Healthy Facebook group, and feel free to share this around with everybody who you think could benefit from this information, because this is really great. And I want to thank you, Amy, for all your hard work. And yeah, we'll keep in touch and we'll keep the conversation going.
Sounds great. Thank you for having me.
For sure. Thanks, everyone.